Welcome to the University of Massachusetts Medical School Central Venous Catheter Insertion Training video. In this tutorial, we will cover all the steps necessary for safe and successful placement of a central line. We'll begin with an introduction to ultrasound guidance of procedures, the preparation and setup you'll need to do to put in a central line, a review of a triple lumen catheter kit, and then specific steps for ultrasound-guided IJ placement and ultrasound-assisted landmark-based subclavian central line placement. Ultrasound has been shown to decrease the incidence of complications and improve success rates in placement of central lines and should be used in preference to landmark-based techniques. For those new to ultrasound, we will first cover some ultrasound mechanics, transducer and image orientation, basic machine settings, and then specific techniques that you can use for ultrasound-guided central line placement. The first step in the use of any ultrasound machine is to understand the mechanics of the machine you're using. In different clinical environments, you're likely to encounter a variety of different ultrasound machines, but at a minimum, you should understand how to select the transducer you're going to be using, how to change the imaging depth, and how to affect the overall image brightness or gain. Important information, such as imaging depth, will be displayed on the screen. In this case, we see a total depth of 5 centimeters. Your ideal imaging depth will be dependent on patient factors and vessel location, but should be set such that the vessel is centered roughly between the top and bottom of the screen. If imaging a vessel in transverse or cross-section, you should position your transducer such that the vessel you're interested in is centered from left to right on the screen. Understanding your spatial orientation is of the utmost importance with any ultrasound imaging. Which direction is medial versus lateral, or superior versus inferior, will depend on the positioning of the probe on the patient and the location of the image indicator on the probe and on the screen. The indicator on the probe is most often designated by a small raised area, either a dot or, in this case, a raised line on one side of the handle of the transducer. On screen, this correlates with the location of the image indicator, which is usually represented by a small dot, in this case, the gray dot that is in the upper left-hand side of the screen. If my probe indicator is directed towards the patient's head, then the left side of the screen would be designated as superior, versus the right side, which is inferior. Likewise, if the indicator is towards the patient's left side, then the left side of the screen is the left side of the patient. Before beginning your ultrasound-guided procedure, be sure you're comfortable with orientation and understanding how the image on the screen correlates with the patient's anatomy. Next, we'll discuss approaches to ultrasound guidance. This includes out-of-plane approaches and in-plane approaches. You are encouraged to familiarize yourself with all of these techniques and find the approach that works best for you. We'll begin with techniques that involve imaging the vessel and transverse. These are called out-of-plane approaches, as the plane of the needle is orthogonal to the plane of the imaging. We'll start by turning the patient's head slightly to the side and placing the probe 90 degrees to the direction of the vessel. This will result in a cross-sectional image of the IJ and the carotid. Again, orient yourself which direction is medial versus lateral on the screen. With the vessel centered on the screen, the introducer needle will be directed at the center of the probe. The two most popular approaches to the out-of-plane technique are the 45-degree rule, or a technique where you follow the needle tip the entire time. In the 45-degree rule, the vessel is imaged in transverse, and the distance from the skin surface to the vessel is measured. The same distance is measured away from the center of the probe, and the needle placed at a 45-degree angle and directed towards the center of the probe. While this technique will reliably guide the needle into the vessel, it is worth noting that no part of the needle, including the needle tip, will be visible in the plane of imaging until it enters the vessel. What you will be able to see is the deformation of soft tissues in advance of the needle tip. In this video, we can clearly see movement of soft tissue above the vessel and even compression of the IJ itself, well before we see the needle tip enter the plane of imaging in the center of the vessel. The key to this technique is paying close attention to the distance of your needle to the transducer and the angle of approach of your needle. Again, be sure the distance between the transducer and the vessel is the same as the distance between the center of the transducer and the needle, directed at a 45-degree angle towards the center of the probe on the screen. If you notice that the needle is missing its target either to the left or the right, it should be pulled back and redirected in the proper direction. In a slightly different but related technique, the plane of imaging can be used to track the movement of the needle tip through the soft tissue by movement of the transducer itself. In this approach, the needle is placed closer to the transducer on a more shallow angle and advanced until the needle tip is visualized on the screen. The transducer is then moved a short distance, and the needle advanced until once again you see the needle tip on the screen. This process is continued until the needle tip is visualized entering the vessel itself. A more technically challenging approach, but one preferred by many more experienced operators, is the in-plane or long-axis approach. In this technique, the vessels are again imaged in transverse, but then the probe is rotated to visualize the internal jugular vein in its long axis across the screen. It is of course important to make sure the vessel you're visualizing is in fact the IJ and not the carotid. With the target vessel visualized, the needle is placed near the probe and advanced within the plane of imaging. This results in visualization of the entire needle, including the needle tip, along its course until it enters the vessel itself. This technique generally requires much more practice, as it requires a skilled operator to maintain a view of the vessel and long axis the entire time and then introduce a needle along that same imaging plane. All of these approaches will require significant practice to become comfortable with the technique. There are a few tips that you should keep in mind, however, to ensure success when you're placing your central line with ultrasound guidance. As mentioned previously, great care should be taken to ensure the proper vessel is being imaged in long axis, as it is quite easy to drift off midline and image the carotid rather than the IJ. Begin by centering the vessel on the screen, and then with the vessel centered, rotate until your image is in long axis. One of the most common pitfalls relates to the improper positioning of the patient and the probe. In this situation, the IJ seems to lie directly over the carotid artery. There's a high risk that the needle in this scenario could pass directly through the IJ and result in an arterial puncture. Even in approaches where the needle tip is visualized the entire time, such as this long axis approach, it is not uncommon for the vessel to be compressed almost completely, such that the anterior and posterior walls completely meet. In that situation, the needle tip can be seen to come within millimeters of puncturing through the posterior wall and would injure any structures that lie in the immediate far field. Fortunately, this situation is easily avoided by simply changing the positioning of the probe on the patient. If the patient's head is turned too far to the side or the probe is placed too far laterally, the IJ will appear to lie directly over the carotid artery, as we are now imaging from a lateral to medial direction instead of an anterior to posterior direction. Simply moving the probe more anteriorly or reducing the turn of the patient's head will reorient the IJ and the carotid in their proper medial to lateral positioning and decrease the chances of inadvertent arterial puncture. While the use of ultrasound greatly facilitates the placement of central venous catheters, it only does so if proper technique is followed. Please spend plenty of time on the simulator practicing all of these approaches until you're comfortable enough to use them in the placement of a central line. Now that we've discussed the basics of ultrasound guidance for central catheter placement, we'll put it into practice and cover step by step all the elements of proper central line insertion. As with any procedure, you should begin by discussing the risks and benefits with the patient and/or family, including obtaining written consent, and then performing proper timeout procedures. Of course, be sure to follow standard hygiene practice, either through hand washing or through use of an approved hand cleansing foam. Next, you'll want to open the package containing your gown, taking care to ensure that the contents inside remain sterile. Your sterile gloves can then be opened and dropped onto the field. On a bedside table or Mayo stand, remove the cover of the central line kit. Inside the package, external to the sterile contents, you'll find a chlorhexidine skin prep wand. Remove the wand from its packaging and squeeze the two handles together. This will break the seal inside, allowing solution to soak the applicator pad. The site of the catheter insertion, in this case the lateral neck for planned placement of an internal jugular line, should be systematically scrubbed with the wand, moving from the center outwards. A complete prep should last for at least 30 seconds. To facilitate opening the kit, it is helpful, but not mandatory, to move the contents to a second table before opening the sterile cover. As you're not wearing sterile gloves at this stage, be sure not to contact the contents of the kit. This is also a good time to open the packaging of the ultrasound probe cover and drop the cover in a sterile fashion onto your field. You'll also want to put ultrasound gel onto the ultrasound transducer. Now that the patient is prepped and the kit open and ready to go, it's time to put on your sterile gown and gloves. After donning a cap and mask, pick up the gown and slide your arms into the sleeves without allowing your hands to emerge from the sleeve ends. Grasping the right glove with the fingers of your left hand through the gown, the thumb of the right hand is placed under the cuff on the back side of the glove. Regripping the cuff on the front side with the left hand, the glove is flipped over the right hand, allowing the fingers to emerge from the sleeve of the gown into the glove. The same procedure is then repeated for the left hand. Next, remove the sterile drape from the kit. You'll notice a diagram indicating the proper orientation of the drape on the patient. Remove the white paper to reveal the sticky backing and place the drape over the patient with the fenestration positioned to expose the catheter insertion site. Unfold the drape, ensuring the patient is completely covered from head to toe. Next, you'll open the kit and prepare the triple lumen catheter for insertion. Set aside the ultrasound probe cover you dropped on the field, as well as the 4x4 gauze pads and instructional material. Before you begin, be sure you're familiar with all the contents of the kit. In addition to the central line itself, you'll find a vial of 1% lidocaine, a syringe, and 2 different sized needles for injection of local anesthetic. There are 2 different sized introducer needles, the guide wire, and a scalpel, 2 different sized dilators, suture material for securing the line, and caps and syringes pre-filled with sterile saline for flushing. In preparation for line insertion, the blue and white ports should each be capped and flushed to ensure no air is introduced into the central venous system during line insertion. First, remove the temporary white caps from each port and replace them with the blue caps located near the guide wire. Then flush each line with the sterile saline provided. Saline should flow easily without resistance from the side ports of the catheter. The red port is the distal port and should be left open as the guide wire will pass through it during line insertion. In an emergency situation, it is also acceptable to clamp each port without flushing. In this case, following insertion of the catheter, all air must be aspirated from each port with the caps in place before flushing the line. Next, open the sterile probe cover. Inside the package, you'll find the probe cover, as well as elastics to hold the cover taut and a package of sterile gel. Place your hand over the top of the cover with your fingers inside the cuff and grab the ultrasound probe without touching any non-sterile surfaces. Pull down the cuff to cover the length of the probe's cord and then position elastics to hold the cover in place. Place a small amount of sterile gel either on the patient or on the probe itself, and then position the probe to visualize your target vessel. Next, locate the syringe and needles for injection of local anesthetic. There is a fine gauge needle for anesthetizing the skin and a larger needle for anesthetizing deeper structures. The kit also contains 1% lidocaine without epinephrine stored in a glass vial. Using a gauze, snap the top of the glass vial off and fill the syringe with lidocaine. While you may find it easier to draw up the lidocaine with the larger gauge needle, be sure to use the finer gauge needle for infiltration of the skin. After identifying your insertion site with ultrasound, make a small wheel under the skin with the small needle, then change to the larger needle to anesthetize the deeper structures. Prepare the guide wire by removing the protective cap from the end of the wire housing. You'll notice the end of the wire is flexible and looped into a J. This should be pulled back into the housing before you begin. Locate the introducer needle and remove its protective cover, then place the needle on the non-threaded syringe. If you haven't done so already, place the patient in a slight Trendelenburg position to dilate the target vessels. Using one of the techniques described earlier, use the ultrasound to guide the needle into the IJ while maintaining negative pressure on the syringe. This will cause blood to enter the syringe as the needle enters the vessel. Carefully remove the syringe and cover the hub of the needle with your thumb. You can then pass the guide wire into the needle. It should pass easily without any resistance and should be inserted to a depth of 15 centimeters. Note the hashtags on the side of the guide wire, in this case noting a 20 centimeter mark short of the hub. Before proceeding any further, it is imperative to ensure the guide wire is inside the lumen of the IJ. This can be accomplished by imaging the IJ in long axis with our ultrasound machine. The guide wire should appear as a hyperechoic structure within the anechoic lumen of the vessel. This important final safety step ensures that we will not dilate or place a catheter inside the carotid artery. Once you're confident that the guide wire is in the IJ, you can remove the needle. You will then use the provided scalpel to make a small nick in the skin to allow passage of the dilator and catheter. Be sure to cover the scalpel after use to prevent injury. Next, the dilator is placed over the guide wire and into the skin and subcutaneous tissue. It is essential that you maintain a grip on the guide wire at all times and that the wire is never advanced along with the dilator further into the patient. Following dilation, the catheter is placed over the wire, again keeping a grip on the wire at all times. This includes grabbing the end of the wire as it passes out of the red port before the catheter is passed into the skin. Failure to do so can result in advancing the wire along with the catheter and losing the wire into the patient. The catheter should pass easily without resistance over the wire and should be advanced all the way to the hub. Once in place, remove the guide wire, covering the red port with your thumb. The port should be immediately clamped or capped to prevent blood from escaping or air entering the central venous system. Beginning with the red port, each port should be flushed to ensure patency. First, all the air must be aspirated from the catheter and cap until blood is pulled back into the syringe. The port can then be flushed with sterile saline. Although the blue and white ports were flushed during line setup, it is good practice to confirm the ability to aspirate blood into the line and then flush with sterile saline once the line is in place. After all three ports have been flushed, the line will need to be secured in place. This is accomplished by suturing the line to the skin with the provided suture. The final step is covering the site with an occlusive dressing. At this stage, the sterile drape can be removed from the patient. This must be done in a manner, however, that does not contaminate the site. After removing the drape, you'll place a hospital-approved central catheter dressing over the line and surrounding skin. All that is left is to order a chest X-ray and confirm line placement, as well as rule out complications such as an iatrogenic pneumothorax. You will then notify the nurse that the line is ready to be used. We will now discuss the approach to central line placement in the subclavian vein. While techniques do exist for dynamic ultrasound guidance for this procedure, they are advanced and beyond the scope of this tutorial. The ultrasound will still be used, however, not only to visualize the vessels prior to the procedure, but also to confirm location of the guide wire in the vessel, much the same as we did with the IJ approach. As the vein lies under the clavicle, you will need to angle the transducer to direct your plane of imaging posterior to it, either from an inferior approach or superior approach. You will see both artery and vein. Remember that the vein lies slightly anterior and inferior to the artery. Scan through the area, making note of where the vein lies relative to your external landmarks. As well, notice how close the pleura lies to the surface and the vessel you will be cannulating. This should help reinforce the need to maintain a shallow approach to avoid causing a pneumothorax. It is worth mentioning that many central line simulators do not have truly accurate anatomy in this area. The pleura is generally not represented, and you may only be able to visualize the vein from superior to the clavicle. After completing the ultrasound and before sterile prep and drape, you'll want to identify the key landmarks for subclavian catheter insertion. These include the clavicle, the jugular notch, and a point 2/3 along the length of the clavicle between the sternum and the AC joint. All of the other basic steps for preparation for this line will be the same as those for the IJ, and therefore will not be repeated in this video. Follow the same techniques for skin prep, draping, and line setup as were previously covered. Installation of local anesthetic is slightly different for subclavian catheter placement. Although you will begin with the same wheel under the skin with the fine gauge needle, anesthetizing deeper tissues must include the clavicle itself, as it will be intentionally hit with the introducer needle during the procedure. Again, palpate the key landmarks. The needle will be directed towards the jugular notch, beginning at a point 2/3 of the way from the sternum to the AC joint. The needle should enter the skin at least 1 to 2 centimeters away from the clavicle so that it can be directed on a shallow angle underneath it. Keep one finger in the jugular notch at all times to give yourself an easily identifiable target. First, advance the needle on a shallow angle until it hits the clavicle, then redirect on an ever so slightly steeper angle to pass the needle underneath it. Maintaining negative pressure while advancing the introducer needle, a flash of blood will appear in the syringe when the needle enters the vein. Before proceeding to dilating catheter insertion, it is extremely important to ensure you have not entered the subclavian artery. Supplied in the kit is a short length of tubing that can be connected to the hub of the introducer needle. With this held vertically, watch for rise of the column of blood. The height should correlate with central venous pressure, usually around 5 to 10 centimeters. After this step, the tubing can be removed and the guide wire inserted through the introducer needle, remembering to limit insertion depth to 15 centimeters. As a final safety measure, the ultrasound should be used again to visualize the subclavian vein and the wire within it. Once you are satisfied with the location of the wire, follow the same procedures as previously described for completing the line insertion. Remember, maintain control of the wire at all times, never letting go at any point until the catheter is in place and the wire removed. As before, you'll complete the procedure by ordering a chest X-ray to confirm line placement and assess for potential complications. You'll then notify the nurse that the line is ready to be used. Whether you're placing an ultrasound-guided internal jugular vein line or an ultrasound-assisted landmark-based subclavian line, be sure you've had plenty of practice in the simulator to feel absolutely comfortable with all aspects of the technique. Following the steps outlined in this video will not only improve your skill in line placement, but will greatly reduce the chances of a procedural complication or line infection. We thank you for taking the time to watch our instructional video. If you are participating in our simulation-based mastery learning for central line insertion, I would encourage you to watch this video not only before your training, but also before your testing sessions. All the information you need to know to pass your test is contained within this video. Wish you the best of luck in your training and in your future career in critical care.